Hi, my name is Gregory Jean Philip. I'm an occupational therapy student. Today I'm going to talk to you about my client, John. He's a 15 years old diagnosed with Charcot-Marie-Tooth disease type 1, known as a hereditary motor and sensory neuropathy. Is an inherited neurological disorder primarily affecting young adolescent and adult. Occupational performance concern for John are is inability to participate in play activity and inability to perform toileting independently. Occupational performance strength are upper body dressing, eating, and CMT is a disorder that causes progressive distal proximal weakness and sensory deficit to the feet and legs, eventually affecting the hands. The three underlying factors and characteristics of the diagnosis that I will address are muscle weakness atrophy, balance coordination deficit, joint contracture, and deformity. The frame of reference that I will be using at first are biomechanical frame of reference and the compensatory. The biomechanical frame of reference, the reason why I will use that because it's a remedial approach for intervention focuses on impairment that inhibit functional performance to remediate existing impairment, prevent further contracture muscle atrophy, to maintain and improve muscle strength. And the compensatory frame of reference is to improve occupational performance. This includes adapting the use of assistive device, equipment to facilitate independence despite the dysfunction. This frame of reference also includes the use of environmental modification to living area and use splint where is appropriate. The two assessments that I will use to assess my client are first is the goal-oriented assessment of life skills, which is a top-down approach which assesses functional motor skills required for daily. It will help me to determine gross motor and fine motor impairment that can affect my patient both home tasks and school participation. And the second one is the BOT tool is the bottom up approach is a bottom up approach assessment of gross motor and fine motor precision, fine motor integration, manual dexterity, bilateral coordination, balance, running, which will help therapists to plan a better intervention, environmental modification, adaptive equipment, and splint that might be needed for the patient. The two occupational based outcome is the use of proper joint protection technique during leisure activity will promote safety and ability to perform lower body dressing independently with use of adaptive equipment. The two occupational goals that I have for John is first one is client will complete toileting with Minasis and 50% tactile cues for hand positioning 3 times out of 5 treatments due to decreased dynamic balance for increased functional independence in daily life within 4 weeks. And the second goal is client will complete bilateral upper extremity exercise against gravity with use of 3 pound weight with mean assist and 50% verbal cues for quality of movement 10 times out of 15 due to decrease muscle strength to improve endurance and muscle strength within 4 weeks. Intervention plan for my client, according to an article, low to moderate intensity exercise should be regularly encouraged as it should have overall systematic health benefit. Interval training, by its very nature incorporating period of rest and exercise, appear to display marked improvement in cardiorespiratory, in strength, in functional capacity, and likely slow or reverse the deconditioning process often seen in patients with CMT. The intervention plan, patient will participate in upper extremity exercise which use a 1 pound or 2 pound weight, which include elbow flexion, extension, shoulder extension and flexion, ulnar radial deviation with flexion extension to maximize upper body strengthening. Patient will be educated also on energy conservation technique to promote ability to perform ADL tasks independently, and will also educated on energy conservation technique to prevent any overexertion. I will upgrade my treatment by amount of repetition or the weight added. I can have my patient use a different weight or more repetition. To downgrade it, I can have my patient perform the same exercise with no weight added, less repetition, and rest as needed. That will downgrade my treatment. Thank you. My name is Gregory again. I'm an occupational therapy student. Thank you for listening.